Welcome everyone. This is our February meeting of our National Rural HIT Coalition. With our co-chairman, Neal Neuberger, we've been doing these coalition meetings for, gosh, it's been about 15 years so far. There has always been a kind of a broad definition of our HIT focus, including telehealth, et cetera. So lately we've had more telehealth kind of focused than at other times, but we're really pleased to have the new director of the Office of the National Coordinator for Health IT with us today. So that's a part of the agenda. We're also going to get some updates as usual from Neal and from Dufault on what's happening in the federal and kind of the telehealth policy world. Mike McNeely from the office or from OAT will be here and kind of bring us up to date on what's happening with COVID-19, just updates in general. And he'll also be including the Federal Office of Rural Health Policy update as well. John Windhausen, who we've welcomed many times to this coalition meeting, is going to be here again talking about infrastructure and the broadband update. And John represents the Schools, Health, and Libraries Broadband Coalition as well. And then finally, we have Jay Shore from the University of Colorado School of Medicine, who's going to talk about rural Tele-Mental health. And, telepsych has been a big application in, particularly in rural America. And I think it really holds some important answers for how we get mental health services and behavioral health services in general out to our rural populations. So with that, again, welcome everybody. One of the things I should say is we are now holding these coalitions every 2 months. Historically, we've done them basically every quarter, and then we would have one in-person meeting, usually in Washington, DC, because we're holding them virtually now. You can expect these coalition meetings every 2 months. And also, as Nicole indicated, we're now recording them. So if you miss them or you want to send them to somebody, we're going to make them available throughout the country. So with that, Neal, as usual, I think you're going to be leading off, and I'll turn things over to you.
Thank you so much, Terry, Nicole, and good to see a lot of you, many friends and colleagues. The good news is that we have, as Terry said, a lot of really great guests today. And so we'll get right into it. And the even better news is you don't have to hear that much from me as a result, because they know more than I'll ever know. I do want to simply reference to start with that we would usually, as Terry said, have this meeting in person at the NRHA Policy Institute. Instead, I was pleased to be able to chair a panel last week that consisted of Brendan Carr, an FCC commissioner, Heather Damaris, Commander Damaris, who's the OAT acting director, and Chad Parker from the USDA. And we talked a lot about broadband and mapping and the extended reach of HRSA and USDA, given the CARES and the CURES Acts and their portfolio, the need for permanency of some of the telehealth developments. We talked about the metrics and how it is over time. We're going to have to evaluate all that has gone on so that we can help make permanent in the minds of the budgeteers telehealth and know that we're doing all of the right things. We talked about training of telemedicalists and the expanded role of TRCs, and we're probably going to hear more about that today from ORHP and OAT. The only other thing I would bring to your attention, and that is also a recorded thing if you didn't happen to be there. The three speakers were really good. I would also draw to your attention an AHA letter that was just sent over recently in the last day or two to MedPAC that is encouraging in many respects in terms of telehealth going forward. AHA has been really a good partner on telehealth. they're calling for the elimination of 1834 geographic site restrictions so that FQHCs, rural health clinics, SNFs, and home can continue to be originating sites for telehealth. They're not calling for parity of payment just yet, but that we move judiciously, I think is a good word, toward improvement of payment, and that we look at something that they're calling a practice expense value and coming up with new ways in which to look at the inputs so as to get proper reimbursement based on those inputs. With that, let me stop. We will reference these things as we usually do in the minutes through Nicole, and turn it over to Graham Dufault, who's the Senior Director of Public Policy for the Connected Health Initiative and the App Association. We often have Graham or his partner, Brian Scarpelli or Morgan Reed, on calls with us. And Graham's going to give us the up-to-date on Congress, HHS, and the states. So Graham, Counselor, take it away. Take about 10 minutes. And thanks again for joining us.
Sounds good. Thank you, Neal. Thank you for the invite and the opportunity to share a quick overview. I think it's a mixed crowd, but feel free to jump in with questions if I'm going too fast or too slow. So in Congress, I think for those who have been following a little bit, you've seen that with the stimulus bills that have passed, came the authority for HHS to waive generally the 1834M restrictions on coverage of Medicare telehealth services. So one of the main things that Congress is grappling with right now is, how do we make those changes permanent? Do we provide a permanent waiver? Do we permanently amend 1834M itself in order to permanently remove the restrictions as they exist? And we're starting to see more proposals that would actually make fundamental changes to the 1834M portion of the statute. So one of the bills that was introduced late last year is called the Telehealth Modernization Act. It provides that a qualified originating site is any site at which the patient is located at the time the telehealth service is furnished. And so that effectively kind of removes the restrictions that have always been in place, and would, from the perspective of Medicare patients, mean that those restrictions wouldn't snap back into place when the public health emergency expires. And I think that's the fear that a lot of elected officials have right now is, what are my constituents going to do if and when, if they happen to be Medicare patients and Medicare beneficiaries, they suddenly no longer have coverage for telehealth services. And so some of those folks are going to be rural. Not everybody who's in a rural area can make it to a qualified originating site and happens to be in a physician shortage area. And so it's an important piece for folks that are represent rural districts, but also members of Congress that represent urban districts, and it's kind of bringing people together. So that's the Telehealth Modernization Act. The Connect for Health Act is the sort of the omnibus telehealth bill, reform bill that has been reintroduced for a couple of Congresses. It's evolved over the years. It generally has as its main provision in last Congress's version has a general waiver authority from 1834M restrictions for live audio and video visits. Now, they just issued an RFI at the beginning of this year. It was due, I think it was the first week in January. And so many of us missed the deadline to respond to comments, but with comments, but they're trying to figure out exactly what the right formula is for the omnibus Connect for Health Act legislation. I think we joined a few other organizations in calling for the lead sponsors to include provisions from the Telehealth Modernization Act, so that we just remove the 1834M concerns. The Telehealth Modernization Act, I should also mention, has that provision. Neal mentioned FQHCs, RHCs. It would have a provision for at least for FQHCs enabling telehealth services to be provided from those facilities. So that's one aspect of it that's also there, and then sort of an expedited means or process for HHS to use to add qualified providers. And then also sort of grandfathers in the types of services that had been added during the pandemic. It's fairly comprehensive in covering some of the major concerns that folks in our coalition have had with respect to the PHE expiring, and so it deals with a lot of the questions that are out there. There's also the Protecting Access to Post-COVID-19 Telehealth Act. That's kind of a mouthful, but that's another bill that also makes a permanent change to 1834M. It would add as a qualified originating site the home of an individual. And then the version that was reintroduced early this year also authorizes the secretary to add qualified originating sites. So it's another really good measure. The CHI has sort of a slight preference for the Telehealth Modernization Act because it just deals with the issue without having the secretary come in. But the Protecting Access to Post-COVID-19 Telehealth Act is also another way of doing it. So one thing worth mentioning is that with all of the stimulus packages that have been passed, there was a general waiver that expires with the public health emergency. Now, the last stimulus package that was enacted into law back in December also included a permanent provision for mental health services. I think it caught a few of us by surprise because it also reintroduces an in-person requirement to establish the relationship. And so there have been a lot of advocates that have sort of provided feedback to Chairman Wyden and others to ensure that potentially that could be addressed. I think there are a lot of folks that have concerns with the in-person requirement as an initial visit to kick off the relationship. So that's the main kind of broad strokes. There's a lot going on. The Telehealth Modernization Act, I believe, is going to be reintroduced next week. The sponsors are preparing for that. I understand it'll be bipartisan once again, and that at least one of the co-sponsors is going to be one of the Connect for Health Act sponsors. That puts us in a good position because with all of these different measures out there on telehealth, I think rightfully the committees are saying, can we all just coalesce on one path forward? And so we are trying to assist with that. And I think, if folks are talking to congressional staff, that's probably what they're going to hear, is that they would hope for just a single solution for this.
And Graham, and I'm guessing the way we're going to get that done is, as usual, when there's a reconciliation like bill up, get of these bills, however those sponsors can, into that 1.9 trillion, additional COVID response folded into budget reconciliation, right? I mean, all the groups are up to now? So
that's a good question. With the $1.9 trillion package, it feels like the telehealth piece is maybe not ready, unless I'm missing something for this. The authorizing committees have kind of all had their turns on the House side on the stimulus package, and I don't think that the telehealth piece was part of Ways and Meanses, and so I guess that's rational because there hadn't been kind of a consensus on which version should be in there, and it would cost a lot. So I agree, though, that they're going to try to find something that's omnibus and a must pass.
Very good.
I'd be shocked if they're able to just do it in regular order and have it go standalone. I think you're right. It's going to probably be on the next one. Hopefully, not probably. Hopefully. I know that John Windhausen is going to talk a little bit more about broadband, but I thought I would mention it really quickly because it's a really important piece. You've got the coverage of Medicare, coverage by Medicare of telehealth services is very important. Of course, the other side of that coin is the 20 million or so, probably more, Americans that don't have access to broadband at home. And so, there are going to be a lot of discussions in the committees of jurisdiction in Congress on what to do about broadband in the future. There are the stimulus provided amounts for COVID-19 specific telehealth, and there have been a number of grant recipients, university health systems, private health systems that have gotten grants from the FCC so far and probably will be getting grants in the second wave. The FCC has a bigger problem because the Universal Service Fund is sort of declining because it's getting the money from landline telephone services to pay for broadband services. So you've got a shrinking amount of money that is going to pay for an expanded set of services and infrastructure. So Congress is going to have to probably do something about that. I'm not sure exactly what that's going to be, and John probably has some thoughts as well. But there are a lot of advocates out there saying we might want to turn this whole thing into an appropriated program as opposed to what it is now. John doesn't want that. Okay, so there are other ways of doing it. Expanding contributions, for example, is another way of doing it. So John is nodding to that one. Yeah. So there are a bunch of different options out there. Somebody's going to have to do something to reform it because we do have an impending shortfall, and that's the sort of the long-term question that I just want to put on folks' radar.
Great. Graham, I really appreciate you being here. By the way, folks, if you have questions, put them into the chat box, or you're certainly welcome to unmute your lines and ask it personally if you'd like. So thanks, guys. I appreciate that. We're going to move on to our HRSA updates, and I believe Mike McNeely is here to provide those updates. Mike?
Thanks, Terry. I was hiding off camera there for a few. Just one thing to address, because Neal brought this up, and I know there were questions that were brought up out of Policy Institute when it came to expansion of the telehealth resource centers. That is not a thing. They are competitive this year. They are funded at the same levels, but the activities have a little latitude, but it's more about the coverage, and that coverage would be including Virgin Islands, Puerto Rico, and then instead of splitting New Jersey and Utah, making them part of specific regions. So I just want to be clear on what that commentary is, because we're not including additional dollars, because I heard that also, and since that program falls under me, I can unequivocally say that it's not expanding in the way that it was interpreted. The other thing, as it relates to broadband, to COVID, we have a broadband pilot program that is funded under the COVID dollars. That was announced at the middle of last month, specifically to check in 4 states and 25 counties, essentially whether or not the broadband capacity, what the capacity needed is in those counties, in those 4 states, as well as what is necessary for telehealth services, and to make recommendations going forward. It's a 3-year pilot program. We're also evaluating it. It included are Alaska, Texas, West Virginia, and Michigan. So we're starting off that. TTAC, our Technology Telehealth Resource Center, awarded those dollars. They actually were awarded $6.5 million to do the actual project. The University of Arkansas Medical Center was awarded an evaluation cooperative agreement to do the work on that. They are working in tandem. We're currently building out those work plans. The goal is to develop the technology this year and then implement the technology next year. And then expanded out. So we have also have a heavy community engagement part of to this project. So we are currently starting the process of identifying key partners in each of those states to ensure that we have the appropriate reach, let's just say. Also, what was mentioned in Heather's update, a new program that will be coming in the summer of 21 is that it will be the Telehealth Technology Enabled Learning Program. It's basically a learning collaborative program that will be focused on chronic disease management in the rural space. It's echo-like, but not echo specifically. There are going to be some other aspects to it. It's not officially on the grants forecast yet, but it will be in the next week or so, because we're in the process of adding that. And we are planning on funding the program at about $4.5 million. This was part of the appropriation, the Coronabus. So it was mentioned in the report language, so that's why I can talk about it. But to that extent, it's something that's on the horizon. Currently, the evidence-based telehealth network program is open, and they are focusing on direct-to-consumer care. And the direct-to-consumer program will, sorry, I'm going blank for a second. The DTC program is open through April. Right now, we had a technical assistance webinar not too long ago. There has been heavy interest in this program. We are awarding up to 11 awards at this point. But you know, we had 145 people on the TA call. So it's just, it is going to be kind of, we're going to see what happens when we get to that bridge. So that NOFO is out on the street, and it is our foray. And as Graham mentioned, that care in the patient home will be helpful if it's continued. We are working in the space to kind of advance it. Things to think about. Yesterday, the National Consortium had telehealth policy update. It is recorded and available on the consortium website. And I know it's available now because I just got an email about its availability. So I highly recommend that. There's also the state updates that CCHP policy, National TRC, has updated their state level telehealth policies. And then I also wanted to make sure I hit on the, where'd it go? The National Governors Association has recently released the future of state telehealth policy, and that's available on their website. It is a HRSA sponsored program that was done under our No Slow cooperative agreement. Other than that, that is, and to address the oat thing, that was a big thing that came out in which is the elevation of the office. Right now, because it's a transition, we're paused just at the moment because we have to wait for the new HHS folks to come in officially. About 40 of them were announced recently, but there are more coming. And so once folks are in place and they can review that elevation, that reorganization package, then things will start moving again. So, but other than that, Bill, do you have anything to add?
Yeah, just one thing. As all of you know, for many years, the important players in telehealth, of course, CMS and the FCC, because they're funding broadband, and sort of OAT was representing the HHS specific policy sorts of interest. It's been really exciting under the pandemic. We have all sorts of federal agencies that were not really involved in telehealth that we're now talking to. We really are all talking together, trying to figure out what works best for the country, and especially for our interest in healthcare. But for example, HUD and the Department of Education and CDC has become extremely involved in sort of telehealth issues, and we're all looking, for example, at all the broadband funding that's out there, because we can't do what we need to do if the broadband's not there. So we're all watching carefully and hoping to make sure all of our beneficiaries are aware of all the opportunities. So it's an exciting time to be in telehealth, and we're all working together as much as we can.
Yeah, I've been really impressed with the work that ODE is doing and the telehealth resource centers as well. They are developing a real wealth of resources, educational, just everything we're going to need. One of the things that our National Rural Health Resource Center is doing is to support ODE and the TRCs to make sure that helping to make sure that our hospitals and clinics understand that those resources are there. So to the degree that we can help to build bridges, particularly through the Medicare Flex programs, we're kind of intent on doing that. And we've lined up some education for our state Flex programs, just to give them a feeling for what is available. And we're doing all of these webinars in partnership using resources from the TRCs themselves. So I would agree, it's an extraordinarily interesting time, and we've had huge advances in both the use and I think the understanding of the value of telehealth. So with that, I'm going to turn things over to John Windhausen, our frequent guest here and participant in our coalition. John, I believe you're here, so you're ready to give us an update?
Yes, I am, Terry. Thank you. It's a pleasure to be here with everybody. I can give you an update about a few things at the FCC regarding their rural health initiatives, and then talk about the congressional legislation. First, on the traditional FCC rural healthcare program, that's the program that's capped at roughly $600 million per year right now. Unfortunately, that program is once again badly delayed in making its funding decisions. I think still we're in February. Only about 20% of the applications that were filed last June have been ruled on by the FCC. So they're way behind again. This is like the third year in a row. The FCC and USAC have not been moving forward very expeditiously. It's very frustrating. We submitted a request. We, the SHLB Coalition, asked the FCC to postpone the April 1st filing deadline that the FCC set a couple of years ago, when it assumed that there was no COVID and it assumed they'd be approving applications more quickly. The April 1st filing deadline made some sense a couple of years ago. It doesn't make any sense today. So we asked the FCC to postpone that deadline for 2 months to give applicants more time to fill out their applications for 2021 funding. And to our great pleasure, the FCC did that. You know, very seldom do you go and ask the FCC, hey, can you do this next week? And they did it next week. So we're feeling good about that. I know this sounds like a minor thing, delaying an application deadline by 2 months, but those who are struggling to deal with COVID and the patients and the vaccines, they are so happy they have another couple of months before they have to fill out those forms and file those applications. Unfortunately, there's still another problem with the rural healthcare program, and that's the database that the FCC created for the telecom program. There's been a lot of work by the FCC staff to try to populate this database of urban rates and rural rates. And I won't go through the intricacies, but the bottom line is we checked some of those rates, and it's going to potentially cause huge rate increases for rural healthcare providers, sometimes tripling their out-of-pocket costs. So we've also asked the FCC to postpone the implementation of this database for another year. And frankly, you know, the Bureau staff, I think they're dedicated to making the database work, so they're kind of dug in, but I think the new chair of the FCC is going to realize this could be a political nightmare for the FCC to basically raise healthcare providers' rates by 3 times during the middle of COVID. So we're hoping that the leadership of the FCC will reconsider and postpone that database for another year. Separately from the rural healthcare program, the FCC is also implementing the COVID-19 telehealth funding. So you may remember last year, the FCC got $200 million from Congress. And then in December, in that COVID bill, the FCC got an additional $250 million for telehealth. And the first tranche of funding actually went pretty well by the FCC because the FCC staff did it itself. They didn't rely on USAC to do it. But in this tranche of funding, the FCC just decided to give it to USAC to manage the second tranche of funding, which makes us nervous because USAC has not been terribly efficient. But that's what the FCC, the new FCC, has already decided that. But nonetheless, hopefully they'll get that funding out the door quickly, and that could be a benefit. Switching over to legislation, you may remember last year we worked with Anna Eshoo on the House side and then Senator Schatz from Hawaii on the Senate side to introduce a bill calling for an additional $2 billion in funding for the FCC's rural healthcare program. And so that bill was not approved last year. We're beginning to think of reconsidering that effort for this current Congress, because basically the COVID-19 bill we see going through in early March. And we're not in that bill now. We did get some E-rate funding, $7.6 billion in E-rate funding in that COVID bill, but nothing on rural health care. So we're thinking of recalculating the $2 billion estimate that we came up with last year. I think we're going to reconsider how we calculated that and try to fold into that analysis what the FCC has already done, what other rural healthcare providers funding they're already getting from the CARES Act, and come out with a new estimate that we'll then propose for the next infrastructure bill. So if we can't get in this COVID bill in March, there is a significant likelihood of a broader broadband infrastructure bill to come this summer. So we're going to try to get our rural healthcare funding into that broader infrastructure bill. I don't know how much it will be yet. We're still doing the math and doing the calculations and the analysis. So that's that. The last comment I'll make, Graham, I'm sorry. I hope I wasn't rude when I was shaking my head at your comments. I mean,
not at all. I was just trying to lay out the options. So yeah.
Yeah, and I appreciate that. You're absolutely right that all of the FCC's Universal Service Fund programs are at risk because that contribution factor keeps going up and up. Basically, the tax on everybody's phone bill that funds the Universal Service Fund has gone up from 20% to 31.8% just in the last couple of years. So this is really spiraling out of control. There needs to be a new method. It's interesting, AT&T is largely the one that's making the suggestion that Congress should fund this Universal Service Fund going forward. And that's word is spreading, but we don't particularly care for that idea because relying upon Congress to do anything consistently year over year is not a stable mechanism. So we think it'd be much better to come up with a new system for the FCC. And basically, I'm coming around to the idea that they really should assess a fee on all broadband services. Basically, the funding is going out to subsidize broadband, so you ought to collect the money from broadband services. There seems to be some parity there. Thank you, Denny. So we, the Shelby Coalition, are working with some others. We're going to try to put a proposal on the table that would have the FCC fix this so that Congress doesn't have to. Now we'll see what kind of traction we get, because anytime you put a fee on broadband services, somebody says, oh, you're taxing the internet. How awful. Well, we're not taxing the internet. We're taxing the on-ramps to the internet, the broadband component. And our analysis shows you could collect all the money you need with a fee of about 2.5%. So compared to 31.8% now, bringing it down to 2%, 2.5%, it's a minimal fee on your broadband bill. We think consumers would be willing to pay that in order to preserve the long-term viability of all these Universal Service Fund programs. So
yeah,
that's my little pitch on that.
Lots to do there. And I know, and we discussed briefly last time, John, Denny's interest in LEO satellites and telephony, especially in rural areas, into expanding. And that's something we're going to want to pursue more closely, both in this set of group meetings and others that Terry and Nicole and I have been talking about. So And I would just comment in conclusion that Commissioner Carr was also very interested in that whole mapping issue. He was on it. So, and you guys have driven that a lot, I know. So lots to do in that regard. So thanks so much for joining us again today. And we'll keep up with you. You turn out an awful lot. The coalition does, and however we can support you, I'm sure we're going to want to do that.
I appreciate that, Neil. Thank you. And I think Denny may have had a question. I'm not sure. But...
Well, my question is, it's a historical question. Is anybody talking about bringing back the REA model and use that as a broadband model in order to get broadband out? And then the second, Neil just kind of talked about is, so we got Starlink up there right now, a private enterprise model. Lots of funding went to it to get to remote areas of the country. I mean, is there some sort of partnership we also ought to be thinking about with Musk and others who are developing that technology?
Well, I guess it's hard to answer that question quickly.
I know.
Yeah.
The FCC has gone, well, I guess one thing that's a little different from REA is that with rural electrification, it was a pretty basic technology, right? You're basically wiring up America. Everybody knew what you had to do. You just needed the funding to go do it. With broadband, it's much more diverse landscape. So you've got satellites, you've got wireless, mobile, terrestrial wireless, you've got fiber. So it's not always clear which solution works best for which rural community, or sometimes some inner city neighborhoods also that lack broadband. So the FCC tried to do this with a competitive bidding process through the RDOF that it just completed, and have competitors bid down the level of subsidy. It's not a bad idea in theory. However, we're afraid they bid down the subsidy too much, too low, and that some of the winners of these bids to get the federal funding aren't going to be able to make a go of it once they get in the field and start to deploy service. So we're really kind of worried some of these operators may not be able to fulfill their obligations to build out in these rural markets. And in fact, Starlink won some of that contract, even though they're still in the process of deploying their satellites. So some people are questioning, well, is that really going to work long term for that satellite technology? We don't know yet because they're just in the process of rolling it out right now. So some interesting questions that are still going to require a lot of oversight.
Yeah, and maybe it's something we can put onto a future agenda as such.
Absolutely.
Let's move on. And Neal, I'm going to allow you can introduce Mickey. He's your friend, and I think we're really pleased to have him here. So
we are. Thanks so much, Terry, and we are so pleased to introduce Dr. Mickey Tripathi as the new head of the Office National Coordinator for HIT. He is, as Terry said, been a longtime friend of ours. He went up to Boston from DC, where he had been one of our neighbors. Him and his wife, Mimi, and his kids and our dogs all had grown up together. And then he kind of disappeared up to the Massachusetts eHealth Collaborative and did great things. And along those lines, got a PhD and became the head of the chief of the Argonaut Project in collaboration around fire and lots of groups, Sequoia Project, Commonwealth Health, was chief alliance officer for the Arcadia Data Project, and has really focused in on interoperability and EMRs over the last 15, 20 years and been a thought leader. We're so pleased that he's been chosen by the administration to be the national coordinator. I hope this is your first public engagement so that we can say we had you on first, Mickey. And with that, and also a shout out to Layla Sammy, who will help guide you in all things rural at ONC. She's been a real stalwart on all these programs and help focus in on telehealth and rural, and we'll continue to do so. So thanks so much, Mickey. Take it away.
Great. Thank you, Neal, for the kind introduction. I really appreciate it. And it's great to see you again, as usual. I see you're in the basement there. So yeah, as Neal said, we've known each other for 30 years. Back when we first met, I was working in the Pentagon, And I, for the life of me, as close as as close as our families were, and as close as Neal and I were, I couldn't figure out what it was he did. Like, I was just like, I do not understand that at all. And it's taken me 30 years, but I think I finally get it, Neal.
You got it better than I ever will, Mickey.
Well, I'm really happy to be here, and I will say up front, I am not an expert in rural health IT, but I'm really eager to learn, and I've got Layla here to support me and educate me, so I'm really delighted about that as well. What I thought would be good to do, I know we've got like 10 minutes and then maybe 5 for Q&A, is just give you a little bit of a sense of what I've been thinking about. I'm on business day 20 here, so I can't promise you that I've sort of laid out the strategy for what we're going to do, but would love to give you just a sense of the various roles we play and some of the thoughts that I have right now, and then really would love to hear from you. So I've got my history has been working in collaborations, so I'm really sort of excited to be able to speak to all of you as a as a health IT coalition. Some of the key roles that I think that we play that that hopefully you're aware of, but just to level set everyone, is standards, and we're very big in harmonizing standards, bringing standards to bear, both not only sort of externally as we think about electronic health records, but across the federal government, and that's at least as big a challenge as doing it in the market as well. So that's one of the big things we work on. We have integration grants, I think, as many of you may know, EHR certification, and then the coordination of federal agencies has been a little bit of as close as I've been to ONC over the years. Now that I'm on this side of the wall, I just sort of more fully appreciate how big a role that is, how important it is, and how challenging it is. And I know that sort of with things that are important to the rural health IT community, working with USDA and FCC and a number of those other agencies, would love to get your input on, how we might be able to do more things there, because I know that's incredibly important to you. And I think of that as, sort of the things that, that from my understanding are important from a rural context are, both about helping to promote interoperability by federal partners. So as we think about the important role that the Veterans Administration plays, for example, across the country, but in rural settings, and the fact that a lot of rural veterans are probably getting their care both in VA-owned facilities, but also in non-VA-owned facilities. So the importance of interoperability and being able to have the sharing of that information, for example. So that's one thing that that we work a lot on, and we had a call this morning with the VA team about how we can help to improve their ability to do interoperability with other non-government provider settings, but also as I said, putting healthcare needs on the agenda for agencies that that may not have it squarely in their agenda. Broadband being a particular example, for example. So happy to talk about that and more fully flesh that out. And then of course information blocking is something that's a new authority to ONC. But we've got the April 5th deadline that is coming up here for the applicability of information blocking. And we're doing a lot of work now to build an education and outreach program to be able to help providers and other stakeholders who are going to be part of information blocking, and to be able to make sure that they have as much information as they can and the tools that they can to be able to move forward with that. A couple of other things that I would just tick off, and then I'm going to stop here, is one is TEFCA. For those who aren't familiar with that, that is a HIE governance that was a part of the 21st Century Cures Act. We've been doing a lot of work in sort of working on the framework for what interoperability and health information exchange governance can be going forward. And my goal for that right now at a high level would be to work as much as we can to be able to make interoperability and health information exchange solutions as widely available and as low cost as possible across the country. I mean, if that's not the goal, then I don't know what the goal is. So working really hard to have that not be yet another layer that adds yet another tax onto an already multi-layered, very confusing, sort of interoperability and HIE, kind of ecosystem is one goal that I'd like to really be able to pursue with TEFCA. Another one is, social determinants of health, and figuring out how we, sort of put that in and make that more and more, a part of what we do going forward. And there's a standards, aspect to that, obviously, and making sure that those social determinants of health are including information that's important that may not be obvious to people, but is important to rural settings as well, like broadband access, for example. That may not be something that's obvious, but you start to think about how important that is in certain parts of the country and saying, how do we get that kind of data incorporated and included there? And that's really important for work done by social service organizations. And as we sort of extend the frontier of what do we think about contributing to healthcare and increasing connections with social service organizations, I think that becomes a part of thinking about how do we get that to be more standardized, more available via the mechanisms that we use for interoperability and health information exchange is one part of, I think, what we want to be able to think about there. The last thing I'll note is, we are not directly involved in telehealth, which I know is hugely important for rural settings. ONC is kind of a service organization, so it's not, normally for us to lead, to go out and say, here is an area that we need to set standards on. That's kind of not, not the role that we typically play. Usually we are the supporting organization for agencies who are requiring telehealth in certain things, for example. So if we think down the path of CMS, for example, and to the extent that becomes more and more a part of the way healthcare delivery happens, and as we think about, a post-COVID world and thinking about how telehealth gets to be a part of that and it becomes, sort of a fundamental aspect of care delivery and payment and all of that, that's where we would come in to say, are there standards that we want to be able to, make sure that that these telehealth solutions are adhering to with respect to connectivity and privacy and security as well. And the challenge for us is is not putting things into the place that start to raise the cost of that unacceptably or inappropriately, right? So that's a little bit of the balance that we're always going to strike in thinking about certification in new areas. So those are just the things I wanted to tick off. As I said, I knew that I only had 10 minutes and I wanted to make sure that I'm getting off the stage and allow the opportunity to have some discussion with you. So I hope that's helpful as, just sort of a framework, and would love to get any questions that you might have.
Yeah, very much so. Really great, and a huge ongoing agenda that you're picking up the reins on here, Mickey. And Mickey's agreed to just a few minutes worth of questions, again, recognizing he's only been there for 20 days and things like that, and can continue this discussion. Mickey, were we the first group to engage you?
Oh, no, you're not the first group, but you're one of the first groups. I will say, though, you are the first group that has the virtual background.
Okay, well, that counts for something. Anybody, questions for Dr. Tripathi? What we have?
There are a number of
Julia, yeah, and Terry, how do you want to do this?
No, I just said, Colin, there are a bunch of questions in the chat here as well, but
okay,
Colin, whomever.
I see Julia Skapik. Do you want to unmute yourself and introduce yourself real quick?
Sure, Julia Skapik, Medical Director for Informatics at the National Association of Community Health Centers. So, and I saw that my colleague Raymond put a comment about social determinants in USCDI in the chat. And I think my question is, do you see the advancement of USCDI as critical, as I think we do at NAC, to improving the ability to standardize and extract data out of EHRs? We're doing a lot of large data projects, and we're still struggling even to get standardized medication and lab data out of EHRs, much less concepts like social determinants of health. If you see that as playing an important role, can you say something about accelerating the rate at which we include new concepts and the support for the actual sort of bidirectional testing of those elements under an updated certification program?
Sure. So yes and no. I can speak to the importance of it. I think it's really important. I can't say anything yet about acceleration of that just because we're sort of getting started. But I will say, as we think about sort of just to back up for a second, the USCDI and the standards advancement process in general, I think those two should be thought of as both together. I think the USCDI is hugely important. I mean, since I spent 20 years on the other side in the market, and the Mass Health Collaborative as well as Arcadia, the company I was with before, we were data analytics companies. We were data warehouses, so we were extracting information out of these EHR systems doing clinical quality measures and other things, and so lived the pain of non-standardized data elements, trying to figure out why is this stuff that's supposed to be standardized and certified EHRs is such garbage and noise that that we're getting out of those systems. So certainly lived that. I will say that as we think about, but I do think that USCDI is hugely important in being that floor that can just keep rising, and that is the common denominator that you should expect from every single system, right? And at least we found that in the market as just hugely important, even though it wasn't sort of as perfect or as good as we wanted it to be. I know we've got the USCDI version 2 out right now for comment. We would love, we're processing the comments that we've gotten, but certainly we've heard loud and clear that social determinants of health and being able to move forward on that is a very important part of that. So we will be looking at all of those comments and taking that very seriously, because I do think that that is a way that we can importantly signal to the market that here's where the floor is rising and here's how fast it's rising. So you need to embrace it and get your arms around it as quickly as possible.
One more question for Mickey while we have him, and anybody? Unmute yourselves or on the chat. If not, we'll thank you and Layla for your time and look forward to this ongoing kind of collaboration. And I'm especially taken with the notion that now the agencies are again cooperating as well as they are and have been, and even more so into the future given the broadband issues and all the crossover between HRSA and ONC and USDA and everybody.
Right.
Really great. And thanks. Congratulations again, Mickey. And
thank you. No, and thanks to all of you. And Layla, Neal, please reach out, let's stay in touch, and would love to on an ongoing basis hear about any issues that you have or your concerns. So thank you very much.
Thanks again.
Absolutely. And we're going to move on into the topic of rural telemental health. And one of the great things about, I've known Neal now for a long time, and the good thing about having Neal around is that when you want a speaker on virtually any topic having to do with either HIT, or telehealth, he always has at least a couple suggestions. And in this particular topic, he suggested Jay Shore from the University of Colorado School of Medicine. And again, I'll leave it to you, Neal, to introduce Jay.
So Dr. Shore is at University of Colorado Anschutz medical campus, where he's the director of telemedicine. And many of us who've been, flies on the wall around telehealth for 20, 30 years have known him in an entire career focused on really standing up telemental health and telebehavioral health and SUD kinds of connectivity and issues, along with Native American populations as part of INHS and with the Veterans Health Administration, and before that with DOD and links with NIH. So I think Dr. Shore gets that collaboration about as well as anyone does, especially around a very defined issue having to do with telemental health. And he is one of the pioneers, along with Dr. Peter Yellowlist from UCal and just one or two others who I can even think of who've done as much as Jay has in telemental health. So thanks so much, Dr. Shore, and we'll turn it over to you. Terry has especially been interested in this topic and something that we're going to want to drill down into more as we get on with it. So Jay, take it away.
Well, thank you, Neal. Thanks for having me on. Just to be clear, I think my understanding is we have about 10 or 15 minutes, and it is a broad field. And I think, Neal, you thought maybe I can make a few comments and just see what questions. I think, Neal, you had indicated in your emails that this group was probably very interested on sort of key policy things going on in this area and the rurality in particular. So I think there are two major themes that I would break down into that have caught my attention during this incredible both good and bad time that we find ourselves in, right? One is the regulation and policy issues. And for telehealth and telemental health, it breaks into 4 major categories. Obviously, the interstate licensure issue, which has always been there and probably always will be there for telehealth, is certainly still there, particularly as people, you know, I know my colleagues, college students, I think sort of really highlighted this as the quarantines began and people couldn't get back or were locked in states and providers wanting to provide care. And the barriers, there have been some exemptions. The barriers came down a little bit. There are some state-by-state COVID exemptions, but by and large, those still remain big barriers. The next one is around prescribing of controlled substances. There's the Ryan-Haight Act, which requires an in-person exam. That's been waived during the COVID emergency, so that helped facilitate telemental health. The third area is billing and reimbursement, with a number of codes being opened up to telehealth and telemental health across providers, and notably telephone. But I'll get back to that in a minute. I said 4 areas. Let's see. Why am I blanking all of a sudden? I've been too many Zooms this morning. But at least in those 3 areas, we've had some relief. But of course, none of us, particularly in billing and reimbursement, which drives funding, I think the biggest question right now for the field is what is going to happen when the COVID emergency expires? Will these exemptions that have been favorable to telehealth remain, or will they revert back? Will there be a transition process? And how do organizations and providers plan for it? I think the other major issue, particularly relevant to rural, is the concept, which is probably new to no one on this call, of digital disparities. And we know there's been a digital divide and broadband issues going on in this country for years. COVID has accentuated those and highlighted those in many areas. I guess the positive side is it's like the Leonard Cohen song, there's a crack in everything and that's where the light gets in. We now really, I think, have stark demonstration of where our digital divides are. And I think there's 4 major issues. There's having the broadband and ability to just connect. There's having the equipment that is paired with that broadband. There's having the digital literacy and comfort to be able to do it, particularly for rural communities. And then there's having funding resources to do it. And so either does your insurance reimburse for those types of services in your area and allow you to access, or are you paying out of pocket, or do you have the money to pay out of pocket for that digital health? And then that transitions back to my comments about the telephone and telehealth. So right now there's sort of some raging debates going on, at least in mental health. We have opened up phone billing codes, which I think has been essential for access to care during the pandemic, because many patients who cannot access a provider via video are at least able to connect with them via telephone, particularly in rural areas. Now, the argument about continuing or not continuing these codes is, I do know as a mental health provider that there are things I would do over video that I will not do over a telephone. What we don't have is the data, the evidence-based data to know whether, can you do an intake as well, or what type of intake, what kind of follow-ups. I can tell you, I know as a provider, a patient I've worked with for 10 years, I'm fine doing a phone call with them and treating them, and I feel like I can give adequate treatment. I probably can't do that with a new intake, so we don't have the data. But the argument of keeping those codes open is that it's the populations that have the greatest digital disparities in access are needing to use the phone to get any care. And so if you begin to shut down those codes, you're creating other barriers. And I think this is a critical issue that people aren't really tracking, particularly for rural mental health right now, around sort of the technology use and reimbursement. So that is sort of my quick take and overview of where we are with sort of policy and digital health disparities. And so are there any questions or comments that
you and I think, and others years ago posited early on that the human dimension issue of acceptance on the part of practitioners and or patients, especially when it came to mental health, could propose it in and of itself a series of issues. And is it fair to say over time, it's disarming in some ways, and that at least on the patient side, some patients find it more accepting than to go to a waiting room in front of a lot of people in a small rural community and be seen getting SUD or mental health services? Can you talk about that and what the real trends have been? And
yes.
Dr. Lord on the phone also might want to chime in on that. Dr. Lord, good to see you.
Yeah, so the data, the data supports fairly high levels of patient and provider satisfaction even before COVID across populations with telehealth. I think the real question is it comes down to individual providers and patients. And there are many diagnoses that may do better in virtual space. And there's some diagnoses that may not do quite as well. For example, there's some literature and a lot of anecdotes about patients with trauma and PTSD that virtual space may create more a feeling of safety and allow them to open up and feel safer in their treatment and make quicker progress and rapport and reliability. To counter that, if you look at patients with dementia, you can work with them over telehealth, but you need to put a totally different structure in place. You're going to need someone on the ground assisting that. So I think the sort of either or proposition that we used to have with the policy discussions is more nuanced now. It's like, how do we use the fit and what's the right technology for the patient in front of us, given the circumstances? And it's been fun to see that evolution. Although I do think there's a group of policymakers and people who are not as familiar with telehealth, and I get frustrated, they're having this either or rather than the nuanced question about acceptance and which type of patients can use telehealth currently.
So we've got some work to make that case. Dr. Lord, you have a Fred Lord from the Kinetic Valley? Oh, he's on the phone right now. Fred, did you want to say something?
I have a question. I'll jump in here before,
Go ahead.
and that is, Graham mentioned that in current legislation, there would be a requirement for a personal visit or an in-person assessment before the telehealth services could click in. From what I understand, that is the ideal circumstances, but I don't think we're talking about ideal circumstances anymore. So, Jay, I'd like to get your opinion on that. Is that a wise section of that legislation, or would you like to see it changed?
So that's just for Medicare, I believe. I hope it's not across the board. I think it's, pardon my French, I don't know if asinine is a French word. But first of all, we have data to demonstrate that that is not necessary. I think it should be at the judgment of the clinician, and I think it's going to create barriers to care and reimbursement for elderly populations that need this care most and have difficulty to access. And I see it moving through. I know there's talk, so it's making me a little nervous, with that population. And that's come up for 20 years because various legislatures or funders do that. That is not supported by 3 decades worth of evidence in telemental health either.
Yeah.
Decision. I honestly think it's a funding resource decision that's being driven somewhere.
Methadone can still not be initiated by telehealth. You still have to do an in-person visit before the patient can start on methadone. Excuse me. Hi, I'll call you right back. So the methadone's out the window. Buprenorphine, yes, I've started people on buprenorphine. on a telehealth visit. I do want to see them in the office though, eventually, for a one-on-one. The problem with, it's not a problem, but what happens with telehealth is that there are some people who do real well with it. There are other people that don't want to do it. They want to come into the office. They want to connect with the person that they're seeing. They want to actually be held accountable to come in, do their urine screen, that kind of stuff. So we've done both of those things. One of the things that we just started to see a little bit around here in our, the northeast node of NIDA up in Hanover, New Hampshire, is at Dartmouth, is starting to get wind of coercive domestic partners kind of sneaking in on patients' appointments, mostly men onto women, so that those appointments aren't really all that effective because the women can't say anything. They're also hijacking prescriptions for buprenorphine, so we're a little bit leery about the full-on. So I think, Jay, your comment that this is a much more nuanced discussion than it can't be black and white. And if there's anybody in Washington who's still pounding that drum, that they got to be disabused of that notion fast.
Well, and I think we're all moving towards, especially after COVID, the era of hybrid doctor-patient relationships, where we hold relationships over multiple mediums with patients, including in person, over video, email, patient portals, and we're tailoring when and how to use the technology per the patient's circumstances. And so, I think there are a lot of patients that benefit from in-person treatment or a hybrid mix of in-person and virtual technology. So to me, that's the exciting thing as we emerge from COVID, of really getting into figuring out that new hybrid environment, which was not very widespread and almost universal because of the quarantines and the pandemic. So as we emerge, trying to figure out, what are the best practices, when to see someone in person, and when to use which technology with which patient. And that's where I think we'll evolve to. I hope our funding will support sort of a broad sway of technologies and let the clinicians make the decisions about when and how to engage, rather than sort of the funding resources. And that's with telephone right now. Yeah, we do not know, I don't think we don't have all the data on who or what can be seen via telephone, but let's let the clinicians make the judgment based on their standards of care and practice and ethics of their professions, and allow them to get reimbursed if they can do it safely and ethically with good care.
And I'll get on my evidence horse for a second. It's been 30 years and we've never actually had all of the funding that we've needed to, nor have we pushed on what works, what doesn't, under what circumstances, and forget the stuff that doesn't work and let's scrap it. And, going forward, instead of just blanket waivers, across the board, especially in a nuanced area like this, we ought to have the literature. I'm hoping that all the universities and I know the TRCs are working on this. That's what I was trying to allude to earlier. That they are doing a great job of having some of those discussions. And it's going to be ARC and NIH and a lot of folks. And we just got to continue to support that sort of thing so that we don't accidentally do the wrong things in this, just when the floodgates are open to telehealth. I'll stop.
Are there any questions for Jay or anybody, or comments on this? I'll just make a quick comment then. A number of years ago, I worked with a team of folks out of the University of North Dakota that went up to Alaska. They had a Tele-Mental health program for veterans, and a lot of the veterans, Alaska has the highest per capita rate of military personnel in the country, and a lot of the veterans came back with PTSD and were really isolated on some of the islands, particularly in southeastern Alaska. And that program was a godsend for those veterans. And they talked about the fact that without it, they would have had to travel all the way down to the lower 48 everybody that I talked to at least was highly complimentary as well. So, you know, we have a lot of soldiers that are still out there with PTSD, and this becomes a real lifeline to them. And you know, it just, we simply don't have the resources available, particularly in isolated areas of rural America, like Alaska, like Montana, and many other places.
Yeah, and I think in rural areas, often telemental health is really the difference between care and no care, because the realities of traveling extended mileage and all that is really not there. There is a portion of patients that will not get the care without the and even more so now during the COVID era.
Thank you so much, guys. We really appreciate it, Jay. We've got just a few minutes left for comments or questions about anything, basically. So we trying to leave some time at the end of our meetings. I think we've got about 5 minutes left if anybody has a comment or a question on any particular topic, or if you just want to give us an update on something that you might be doing. Well, with that, I'm going to make one more comment, and that is anecdotally, at least, what we are hearing on this topic of mental health is that the social isolation, the fear, et cetera, is creating pretty significant mental health problems, you know, with patients and healthcare providers in that regard. And so I'm wondering, is anybody really taken a look at that? Is that something that particularly those of you who are clinicians are picking up in terms of, I mean, is our mental health in rural America getting worse? I'm just wondering if anybody has an observation on that. Jay, what about you? Are you picking anything up on that regard? Are you expecting greater mental health problems because of the COVID pandemic?
So the data is bearing that out. We certainly having greater rates of depression, stress throughout society. We're seeing, at least, and then anecdotally in the organizations I work across, we're seeing just, I mean, there was always demand for mental health, but growing demand. I think also the data from disasters, and we're really in the middle of sort of a big natural disaster. We can expect rates across all mental health disorders, particularly depression, anxiety, and substance abuse, to rise. I'm concerned around suicide. There's some anecdotal data, but we haven't seen, the data hasn't really caught up, but I suspect we might see an increase in that. We certainly have seen an increase of opioid overdoses during this time as well. So it is concerning. And I suspect too, you know, in mental health, the resource pie hasn't grown proportionally. And I think we're going to see a number of resource issues, not just in mental health, but in the country. And so as we have increased demands, I'm not sure there's going to be increased resources towards mental health in the next year or two. So I think we're going to have some interesting challenges in the field to have to arise to manage. And we may have to look at better population health models of population-based mental health care, integrated care, more preventive models, just to be able to meet some of the needs that are there, and I anticipate growing over the next 6 to 18 months, unfortunately.
You know, there's an accompanying cost factor here as well, because the data that I've seen shows that the cost of somebody, let's say, with a chronic illness and depression or behavioral health problem basically sometimes triples. And so as we're moving into our value-based models, it's going to be extremely important. That's one of the things that's coming up from the accountable care organizations and from the folks that are participating, is the cost of mental health is astronomical, you know, overuse of the emergency room, et cetera. So you know, there are all these needs out there of our patients, but also it's becoming very, very clear from the data that the cost itself is driving a lot of the inflation in our healthcare costs. So with that, I'm going to thank all of our speakers. I thought you guys did a really terrific job. We are at the end of our time. Nicole, any final words from you? You're around.
Yeah, I was looking for my mute button. No, thank you so much, Neal, for helping identify speakers to come on this call and getting Mr. Tripathi to come and talk to us a little bit about what he sees going forward with ONC. And that's it. Thank you, everybody, for joining. We'll be in touch soon when the recording is available and let you know when the next call will be. That should be in April sometime. So look forward to seeing you all again, and reach out if you have any questions.
Yeah. Thanks
Thanks
everyone.
all. Stay safe.
Yeah.
Thank you.
Bye-bye.